In this next section, we're going to talk about some of the adverse reactions that can happen with local anesthetics. So the objective is describe the toxicity associated with the systemic administration of the local, and particularly we want to focus on bupivacaine because that's something we use very often in the operating room or in the emergency room, and the risk of toxicity can be real. So, important adverse effects of the local anesthetic, although are rare, but occur usually from the systemic absorption, local tissue toxicity, allergic reactions, and some drug-specific effects. Systemic toxicity of the local anesthetics happen when their plasma concentration is too high, and usually it happens after the accidental intravascular injection. When doing a nerve block, but can also happen from absorption of local anesthetic from tissue injection site. How much local anesthetic is absorbed to the blood depends on the dose injected, the site of injection, and its associated vascularity, and if we added a vasoconstrictor to the solution of the local anesthetic. What is systemic toxicity? It's when CNS and the cardiovascular system have clinically detectable effects of the local anesthetics. But we know the maximum acceptable local anesthetic doses that should limit plasma concentration to prevent the systemic toxicity. But keep in mind that the standard dosage recommendations are not evidence-based, are inconsistent, and they fail to take into account the specific injection site and the patient-related factors. So these are guidelines for providing a starting point, and you need to adjust the dose based on clinical circumstances and evolving evidence. For example, if you inject 1 cc of 2% lidocaine, which is 20 milligram of lidocaine in the carotid artery, your patient will seize. But I routinely inject 1 milligram per kilogram of lidocaine in the peripheral IV to decrease the pain of propofol injection with no systemic effect. Now, degree of toxicity can be mild or early, which manifests with agitation, lightheadedness, altered mental status, some visual changes, slurred speech, hypertension, and tachycardia. And moderate toxicity can happen with CNS excitation, cardiac dysrhythmias, and seizures. And when it's severe, the patient will be hypotensive, bradycardic. You're going to see ventricular dysrhythmias and cardiovascular collapse. Now, when it comes to central nervous system toxicity, increasing the plasma concentration of the local classically produces a circumoral numbness, facial tingling, restlessness, vertigo, tinnitus, and slurred speech. And this can result in a tonic-clonic seizure through a marked variation from this pattern is quite common. So it doesn't always happen in an order, and not all of them always happen. Local anesthetics inhibit neuronal activity, but initially they selectively depress the cortical inhibitory neurons and leave the excitatory pathway unopposed, so this is why patients seize first. But when you keep upping the dose, now the excitatory neurons are affected too, so the patient goes into a coma. And this is kind of similar to what happens with alcohol. You drink a little bit of alcohol, you get excited because the inhibition is affected, and you drink a little more, then everything is affected, so people pass out. This is not entirely the same mechanism, but it's a similar point. When patients are seizing, they're not breathing, but they continue to make carbon dioxide at a much higher rate from the muscle activity that happens with tonic-clonic seizures. So they become hypoxemic and acidotic, and acidemia potentiates their CNS toxicity, if you remember the pKa section. Now, cauda equina is a rare complication of spinal anesthesia, usually or historically with lidocaine injection for in the intrathecal space. It's usually manifested as a prolonged neurologic injury with both sensory and motor component. The motor component is an important factor to remember. The risk factors include the use of preservatives, use of high concentration of chloroprocaine or lidocaine, and use of micro catheters for the continuous spinal infusion. And that's probably because the catheters allow a high concentration of the drug to accumulate near the sacral nerve roots. Historically, preservatives or other contaminants injected with the lidocaine were blamed, but this neurotoxicity has been seen following injection of high concentration of both chloroprocaine and lidocaine independent of the preservatives used. Now, transient neurologic symptoms or TNS is the reason that lidocaine is rarely used in spinal injection. It manifests with severe pain radiating down both legs, which is temporary but can last for hours, days, or even rarely weeks. There is no motor component to it, so it's only sensory and it only manifests as pain. And the risk factors include surgical position, specifically lithotomy position, early ambulation after spinal, and obesity. And this poses a special problem when spinal anesthesia is chosen for short procedures because there are few alternatives for outpatient regional anesthesia. Now, when it comes to cardiovascular system toxicity, and just remember that the cardiovascular system is generally more resistant to the toxic effect of local anesthetic than the central nervous system. But high plasma concentrations of the local anesthetic would directly depress myocardium and vascular smooth muscle, so the patient becomes profoundly hypotensive. The cardiac toxicity happens because the local anesthetics block the cardiac sodium channels, so we get impaired cardiac automaticity and conduction, and on EKG you can see prolongation of the PR interval and widening of the QRS. They can also directly affect the contractility, which compounds the problem, but different local anesthetics have different degree of effect on the systems. For example, the ratio of the dose required to produce cardiovascular collapse compared with that producing seizures for lidocaine is about twice that of bupivacaine. So bupivacaine is a more potent cardiac toxin than lidocaine, even though both result in the same pathophysiology with high enough dosing. Now, lipid resuscitation is a newer life-saving technique that makes the use of the local anesthetic, particularly for epidurals and regional anesthesia with peripheral nerve blocks, very safe nowadays. But how does it work? So let's say we gave a big dose of bupivacaine to a patient and he's seizing. You know the next thing is cardiovascular collapse. So while doing your ABCs, you also call for intralipid. So what is a lipid sink? It's the non-specific extraction of local anesthetic from aqueous plasma or cardiac tissue or any other tissue. And it goes down the concentration gradient and into the lipid droplet. So the way the lipid reverses local anesthetic toxicity may be increasing its clearance from the local cardiac tissue, for example. But another possible mechanism is that the lipid counteracts the local anesthetic inhibition of myocardial fatty acid oxidation. So they reverse the cardiac depression by restoring the energy production. So, like many things, when it comes to local anesthetic, there's a lot of unknowns, but there are a couple of theories, and both of them could be true or could be one or the other. Methemoglobinemia. So prilocaine is an older anesthetic that's not used as much for injection, but it's commonly used in sprays that people use for treatment of sore throat. It's metabolized to liver to O-toluene, which oxidizes the hemoglobin to methemoglobin, and we generally need a high dose to get clinically significant methemoglobinemia, and that's usually over 600 milligram of prilocaine. When you have methemoglobinemia, based on the way our pulse ox sensors work and the absorption of light by methemoglobin, the pulse ox reads somewhere between 84 to 86%, no matter what the true saturation is. When it happens, we can treat it with methylene blue, and the dose of that is 1 milligram per kilogram, and that reduces the hemoglobin back. The true allergic reactions to local anesthetics are very rare, and only about 1% of all the adverse reactions to local anesthetics are caused by true allergy. Most adverse responses attributed to the allergic reactions are really due to the additives or a manifestation of systemic toxicity from excessive plasma concentration of the local anesthetic. For example, hypotension associated with syncope may be psychogenic or vagally mediated, or tachycardia and palpitations may be from the systemic absorption of epinephrine that was mixed with local. That's happened to me a few times in the dental office. Now, the amino ester local anesthetic produce metabolites related to para-aminobenzoic acids, so they're more likely to cause hypersensitivity reactions than the amino amides. Cross sensitivity doesn't exist between the classes of local anesthetics, though. And this is where the classes would be esters and amides. But allergic reactions may be caused by the methylparaban or similar compounds that resemble PABA, which are used as preservatives in the commercial formulation of both ester and amide local anesthetics.